Everybody. I'm Harrison Reed. I have the pleasure of moderating the next panel for you all. So far, I've very much enjoyed that last panel, so I hope we can keep the good times rolling here. For the next hour and a half, we are going to be having a panel on key considerations for workplace wellness. We have three speakers today. We have Dathian Sturgis, Stephanie Neary, and Heidi Brown, who are going to be collectively talking about critical workplace considerations like imposter syndrome, vulnerability, self-disclosure, and the role of a personal burnout plan in supporting clinician wellness. So our first session is by Dathian Sturgis. Can I get a confirmation that he's available? Awesome. Excellent. Dathian talked yesterday, but I think he certainly deserves a reintroduction, if that's all right with everyone. So I'm going to go ahead and reintroduce him. This is Mr. Dathian Sturgis, MPAS, PAC, CAHIMS, CHES. So Mr. Sturgis has been a PA since 2008 and a PA educator since 2013. He's an assistant professor at the University of Washington MEDEX Northwest PA program. He also serves as the APD of Regional Affairs, Justice, Equity, Diversity, and Inclusion. And he's maintaining a clinical practice in family medicine within the UW system. His passion is providing care to underserved populations. He also serves as the chair of PAEA's Diversity and Inclusion Mission Advancement Commission. He serves as a Faculty Skills 101 workshop facilitator and as the Cultural Perspectives editor for the Journal of Physician Assistant Education. He is currently embarking upon the dissertation phase for the PhD degree in health studies at Texas Women's University, where he also completed a postmaster certificate in interprofessional informatics. His dissertation is studying perceived burnout in underrepresented minority PA educators in the United States in order to inform future health interventions. So without any further ado, I'm going to turn it over to Mr. Sturgis right now.
Hey, good morning, everybody. So let me... Harrison, pop back on right quick so you can give me a thumbs up if you see my screen. Okay, good. Thank you. All righty. Okay, so this morning I'll be talking to you about imposter phenomenon and how it intersects with burnout. And to just ask the question, is there a relationship between these two phenomenons among clinicians? So the objectives this morning, I will define imposter phenomenon, or some people refer to it as imposter syndrome, and discuss the relationship between imposter phenomenon and burnout. So first, I must acknowledge that I'm presenting this morning from indigenous lands. The Sammamish as well as Duwamish tribes were inhabited the land that I stand on now here in Capitol Hill in Seattle, Washington. So I just want to say thank you and acknowledge our indigenous peoples. So I love Maya Angelou, and as you all know, she is one of the most prolific poets, writers, scholars that probably have existed in the past century or ever, maybe. But when we talk about imposter syndrome or imposter phenomenon, no one is immune, even her. So at the time, when she had about 11 books, she said, I've written 11 books, but each time I think, uh-oh, they're gonna find me out now. So we're gonna dig a little deeper into maybe what does that mean, and why would someone, even of her stature and her level of accomplishment, think that way about herself? So before I moved up here to Washington, I was on faculty at UT Southwestern down in Dallas, Texas. And I began doing some research on imposter phenomenon, and I'll tell you a little bit of history behind it here soon. But I just gathered together a few of my underrepresented minority students and asked them a question about, how do they feel being here? What thoughts are in their heads? And I asked them to write it on a poster board, and if I could share it. And so I've been sharing these words that they wrote yearly. Each time I give a talk like this, I make sure I include this, because what if these imposter feelings went unchecked within these students? So we have Van Lee, who said her presence at MPA school, she said, this has to be a mistake. Stephanie said, can I do this? And Jayla said, I don't belong here. Destiny, who's a 4.0 student, actually said, I'm an imposter. Chris said, did I earn it? And Alexis said, I guess they had to fear their quota. So these are highly intelligent, worthy students that are matriculating through PA school, and come to find out these are the feelings and the thoughts that they are walking around with daily, that had I not asked, I would not have known that this is how my students are feeling. So just imagine if we don't acknowledge or normalize this or try to thwart some of these feelings when they're PA students. Just imagine the stress that comes with being a clinician. And we all know the stress that comes with being a clinician. So that just exacerbates these imposter feelings that they are having. So, people have probably been feeling like this for eons and eons, but in 1978, two researchers, Clance and Imes, actually published a paper in Psychotherapy Theory, Research and Practice about imposter phenomenon and what they described as this feeling of imposterism and feel like the rug is going to be pulled out from under you, a feeling of I don't belong. But it first was recognized in high achieving women. So, for example, women who were CEOs or directors who sat around tables that were full of men, and they would sit there and sometimes think that, what, I'm not worthy to be here. Oh, I'm just here because I'm a woman. They needed a woman around the table. I need to work twice as hard so I can be respected amongst this population. So they first started looking at it among high achieving women. And people who have imposter phenomenon believe that they are not very smart, and they actually believe that they are what we call an intellectual fraud. So no matter the intellect that they possess, they've convinced themselves that what, this is by mistake or this is by chance, and I'm a fraud. So I'm living in this constant state of angst, waiting to be found out that what, I don't belong here. Someone's going to catch this mistake one day, and I'll be gone. And so they operate in this daily fear of being discovered, as an imposter. And as you can tell, that's probably not a good that does not lead to a good sense of well-being. And it actually leads to these clinical symptoms like generalized anxiety. It decreases their self-confidence. It can lead to high depression scores. And that increased frustration is usually secondary to their inability to like internally process um, these imposter feelings. And then they set these goals to make sure that they stand out amongst the rest to prove themselves. So they have this inability sometimes to achieve these high standards that they set for themselves. And I'm using themselves, but let it be known that I suffered from imposter phenomenon, and still to this day I have imposter thoughts, but I have the tools to get rid of those whenever they do come up. So I call it the inner saboteur. So that's why I have these boxing gloves here, because we have to fight that inner saboteur that is just eating away at our confidence, at our self-efficacy. And the thing about imposter phenomenon is that it can affect all people. It's not just one group, but recent research has shown that there are higher imposter phenomenon scores amongst women and amongst minority groups. And that comes with this pressure to achieve. It's always this pressure to beat the last thing that I just did. So I have to go above and beyond. Well enough is not good enough. So this pressure to excel and demonstrate success, to prove that I'm not a fraud, or to prove that I can continue keeping up this farce to stay here. Um, so people who even have imposter phenomenon have a difficulty internalizing positive performance. So for example, if you studied hard and you got an A on a test, most people will celebrate and be happy about that. But those who have imposter phenomenon think it's by luck, by chance. They're waiting for the ball to drop. So they don't take the time to practice mindfulness to smell the roses. Just harkening back on what Eve was just talking about, and they usually, like I said, attribute their successes to the external things like chance or luck, when actually they're good, they're well, And what they're showing is their ability to succeed. However, this inner saboteur is always doing this tug of war with our psyche. So that inner saboteur too, so that constant battle actually can lead to lower self-esteem in those individuals who have IP. And that cumulative effect actually can lead to psychological burden, like we just talked about, with the general anxiety or increased depression scores. Um, it can lead to self doubt, anxiety, as well as apprehensiveness concerning their performance, especially in non inclusive spaces. So we want to think about, if we're thinking about gender, a lot of times different professions are male dominated. So women may feel that self-doubt or that double doubt. If you were here yesterday, what I mentioned about people they feel consternation or don't trust what a woman says, or compound that with a woman gender and race, like a Black woman. And so these non-inclusive spaces can be PA schools. We talked about yesterday too, diversity without inclusion. So you can have one or two others, and but now have inclusive practices, and that can lead to self-doubt. So it's like, okay, am I here because I'm the token? Like, you can reflect back on what Alexis said. She said, I think I'm just here to fill a quota, right? So we have to consider these in our organizational policies and procedures as well. And so these negative effects can actually be compounded with experiencing microaggressions or macroaggressions, and with the institutional policies that are at play. All of these things combined can actually exacerbate imposter phenomenon in those where it remains unchecked. So how do we help fight the inner saboteur? What can we do as colleagues, as directors, as bosses, as friends, or just within ourselves? What we have to do is normalize each other's experiences. That, at maybe you don't, it's not pervasive, but at times we have all had some imposterism that has kind of showed its ugly head from time to time. We need to help reinforce that, we are not alone in this, and these feelings are not isolated. That, we might have some shared experience around this. So that normalization actually helps bring it down from a level 10 to maybe a level 5, to say, oh, someone else is feeling this. So it invites that conversation and that internal and external dialogue. And so if you have experienced IP before, or if you're experiencing it now, please share your story, share your personal experience with others, because you never know who is going through this same thing. So when you're talking to people or you're mentoring someone, share your stories of, what, sometimes I feel like I don't belong here. And I have to get rid of that stinking thinking, is what I call it, and throw it out the window. And you want to help reinforce to your colleagues that they're here because they deserve to be here. You're practicing PA, NP, MD, whomever, because you earned your spot. You have made it through and you're here, and it's not by mistake. So we want to dispel any false thoughts that people may carry in their head. And just like I said, words and personal experiences can help do that. And then in your organizations, you want to help to establish a safe, but we go beyond safe to say brave space for discussions. And above all, you just want to listen sometimes, invite people to share with what they have in their hearts and in their minds. Like I said, just asking them to write that on a poster board was so powerful, because had I not listened or asked them, I would not have known that. So a way, if you want to officially see, hey, do I have imposter phenomenon? Dr. Clance actually came up with a validated and reliable screening tool, which you can Google, called the Clance Imposter Phenomenon Scale. And what it is a Likert scale with some different quotes and thoughts. And you just rank yourself across this Likert scale. And from there, you calculate your score. So after taking that test, you add together the numbers, and then you will see what your total score is. So if your total score is 40 or less, then you have a few imposter characteristics. If that score falls anywhere between 41 and 60, you're on the moderate scale. And then if it's between 61 and 80, that means you frequently are having imposterism. And then if your score is above 80, that means that you have intense imposter experiences. And so that just kind of helps give you a tool to see, you know what, I'm thinking these things. I want to, for us researchers out there, us social scientists and clinicians, might want to see, give me a validated tool to say, do I have imposterism? This is one. So you can go and Google it and take that. So let's talk about intersectionality. So, that's one of my favorite words. So the intersection of imposter phenomenon and burnout. So we talked a lot about burnout over the past day and a half here. And what the research is showing, so there's not a lot of research out there about this. So again, this is our lane. We can go forward in this lane. So there is an interaction between imposter phenomenon and burnout. So one would naturally think, knowing what imposter phenomenon is now, after getting a little bit of background on it and being familiar with what burnout is, it naturally has an interaction. So one of the scary things is that researchers have shown links between those who have imposter phenomenon, burnout, and it leads to suicide. Because of that increased psychological burden, or people feel like they're stuck, or they're trapped, or that increased allostatic or cognitive load people are carrying, trying to put up this farce, saying that I'm a fraud, compounded with burnout symptoms. So if that goes unchecked, that can actually lead to suicide. And we see that a lot in our medical profession, that suicide rates do increase amongst clinicians. And so we've become familiar with burnout being an active contributor in health professionals. But then you want to add on top of that the layer of imposter phenomenon. So imposter phenomenon is actually an active contributor to burnout. It's one of those contributing factors. And we know that there's increased levels of burnout amongst health professionals. So those imposter symptoms actually can lead to emotional exhaustion, which we know is one of the leading tenets of burnout. It's the most validated, reliable subscale that predicts burnout, with a reliability of about 0.9, if that means anything to you. So some researchers, Gottlieb, actually places extra importance on understanding imposter phenomenon. And we want to understand that within the context of burnout, because of its profound impact on medicine. This is a stressful job. We talked about emotional labor. We talked about some of the external contributors that are happening on the organizational scale, as well as the interpersonal and intrapersonal relationships that actually can compound and lead to burnout too. So adding on top of that, the intrapersonal contributor of imposter phenomenon. So why is it important? So when we're sitting on admissions boards, or we're coming up with the prereqs and requirements to enter into one of our health professions, we actually are self-selecting most times for people who are type A, who come in, who are very driven, for people who have a sense of competitiveness, especially in the medical school piece of it, because they're ranked, and then that actually contributes to what type of residencies they can match to. And those who are willing and able to endure PA school or NP school or medical school or any type of the health professions. And we all know the intensity and the academic rigor that comes along with that. Then on top of that, we do have conflated expectations on their achievement levels. So we actually are self-selecting for these people to come into our health professions. And so with that, if we're self-selecting for that, we need to know how to put out some of these fires, or assess and address some of these phenomenon, including imposter phenomenon and burnout, that can affect our students who will become our future clinicians. And so remember, our ultimate duty is to protect the public trust, which means we also need to protect our clinicians so that they don't make errors or do self-harm to themselves. So these attributes can actually lead to burnout as well as imposter phenomenon, with imposter phenomenon actually being the strongest predictor for leading to that psychological stress or psychological burden in individuals. So looking at gender among medical students and the relationship between imposter phenomenon and burnout, a study showed that there is almost 50%, so 49.3% interaction with the female gender compared to male counterparts of 23.7%. And then there's also a relationship between race and imposter phenomenon, and that was trending towards significance, but it wasn't a significant finding that compared Asian groups and white groups. And so that was at 30%, then compare that to all races, so underrepresented in medicine races, and that was above 70%. So there is a trending towards significance correlations between race and imposter phenomenon as well. So in that same study, imposter phenomenon was actually significantly associated with burnout contributors to include the physical and mental exhaustion pieces, cynicism, as well as depersonalization, which are two of the subscales, emotional exhaustion, and depersonalization is kind of sometimes used interchangeably with cynicism. It's also a subscale of burnout. And so what they found is that people tend to try to overcorrect. Remember, because they are thinking that, hey, I'm a fraud. And that those feelings can actually lead to burnout. So in women, they tend to try to face their doubts head on and compete even harder to show that, hey, I need my seat at the table is earned and I don't want you to pull it out from under me. Compared to men who tend to avoid areas that exacerbate them being vulnerable. So they will just avoid that trigger or that stressor. So typical symptoms of burnout actually can lead to symptoms that mimic depression. So for associated fatigue, you're not concentrating as well, having trouble sleeping, being irritable, and that depersonalization, like, you know what, I'm disconnected from the world around me. I might feel like I'm going to work, but I'm watching my day on TV. It doesn't feel like me. I'm just going through the motions. And these are, as we know, are also symptoms that lead to depression. And so the data support that over 50% of individuals with burnout actually meet the criteria for clinical depression. And so at the intersection of imposter phenomenon and burnout, these results end up in a compounding effect. And so that leads to increased psychological stress, and it also results in suicidal ideation, as mentioned earlier. And we see that in medicine, men physicians are twice as likely to commit suicide, and women physicians are 3 times as likely to commit suicide as compared to the general public in this country. And if you just remember kind of the groups that are more disproportionately affected, this makes a little bit of sense, especially with putting gender in it. So the women are actually more likely than men in the health professions or as a physician to commit suicide. So we see that this is dangerous. It's not just talk. It's not just flowery talk. This phenomenon is actually can lead to death, and it can lead to decreased health. So when it comes to, okay, is there a relationship between imposter phenomenon and burnout? Simple answer, yes. But then looking at all the different research, the jury is still out. So research has not shown the direct impacts of imposter phenomenon and burnout and what they have on each other. So boom, there's a lane for us. However, some studies are showing that those who experience burnout are more likely to report imposter symptoms. And so amongst our clinicians, burnout continues to rise, which is why it's so important for us to have these types of conferences and to get the tools we need to adequately address burnout at the organizational level, at the individual level, more so in a combo intervention. And it shows that, there is a direct correlation to IP, but still the jury is out because of the conflicting studies and the conflicting findings. And so intersectionality exists. So where do they cross? So looking at this study amongst general surgeons and some surgery residents, the study showed that burnout symptoms were significantly higher in individuals who also had impostorism clinical symptoms. So someone who scored high on the imposter scale and exhibited some of the impostorism symptoms actually had higher levels of burnout or experiences of burnout. And there was also a positive correlation between the symptoms of burnout as well as the clinical symptoms that are associated with imposter phenomenon, looking at the medical residents. And so again, when you talk about the research that exists in this realm, it is limited. However, the exploration into this relationship between imposter phenomenon and burnout continues. So people are finally doing the work, and we need to look at it too amongst our advanced practice provider population. So I want to leave with a quote, and this quote says, "It's not what you are that holds you back, it's what you think you are not." So let that sink in. So those imposter symptoms, those imposter thoughts, that stinking thinking, is not what you are that holds you back, it's what you think you are not. And that's by Dennis Waitley. So I will entertain questions during the Q&A part. And I just want to say thank you again for allowing me this brief moment this morning to tell you about the intersection of imposter phenomenon and burnout. These are my references you will see when they share slides, and I thank you.
Thank you very much, Dathan. We do have some questions. I think we'll probably save those for the end of all three presentations, but certainly a lot of interest in this topic for sure. All righty. So we're going to move on to our second speaker of this panel group. We have Ms. Stephanie Neary, MPA, MMHS, PAC. She's going to be talking about vulnerability and self-disclosure. I'd like to just take a moment to introduce her. Stephanie Neary is an assistant professor and the director of didactic education for the Yale PA online program. She joined Yale in 2017 after leaving full-time practice in family medicine and now works PRN in inpatient endocrinology. She's a 2020-2021 PAEA research fellow, and she's in the PhD in nursing science program at MUSC. Her area of research is in student well-being, working to create learning environments that promote the development of personal wellness alongside the development of clinical acumen. So without further ado, I will turn it over to Stephanie Neary.
Sorry, unmute. Hi, everyone, and thanks for having me today. And Dathan, thanks so much for sharing that. I think it goes really parlays well into what I'll be talking about here as well with personal vulnerabilities, and then how do we actually draw upon our own experiences, one of those things being imposter syndrome that a lot of us face, and how do we kind of move that into bettering ourselves and the people around us, whether it's our students or in our workplace. So as Harrison said, I do work full-time in education, and so a lot of my examples and the things that I draw upon in my research and that I'll be talking about here does deal with the student population, but I will try to highlight how that can move over into clinical practice as well and among our peers and our colleagues in this space also. I also just want to take a second to acknowledge Indigo Weller on the call here and Eve Hoover, who I saw is on here as well, because a lot of the work that I've done that I'll reference through this is a collective effort of a larger team, and they've both done a lot of that work as well in developing a lot of these things. So thank you guys, and you'll see some of the work that we've done here as well. So let me go ahead and progress here. So our objectives really want to introduce this idea of vulnerability, relate it to ourselves, to our clinical practice, some of the barriers and what it actually looks like to be vulnerable, what we mean by that. And then exploring a little bit into self-disclosure and the different types of self-disclosure and what that can look like and how that can affect us. So I have nothing to disclose. So just a little bit of exercise to get us started. And I do this with my students sometimes as well, but if you can take just a second and think about what you think about when you hear the word vulnerable, what words come to mind for you? And then if you think about a time that you were vulnerable at work, so that you've actually shown your own vulnerabilities. And then if you can think about a time when a peer was vulnerable at work, so maybe a little bit harder. And then the one that I really struggled to find an example of for myself, even for this, was a time when a mentor or a superior was vulnerable at work. So when someone else, that I work with has actually shown this. So a lot of the work that I do, I like how Dathian talked about sharing your story. And when we do some of these different exercises that I'll reference, this is how I frame it to students, is that we call them shared stories exercises, where I typically will start with something and talk about something, and we kind of open up that discussion to the group. It does take a little bit of time to do this. And I think that, there are a lot of things that need to change that we talk about with wellness and structural things and system-wide changes. But what we have control over is the way that we present ourselves, the way that we speak to those around us. And I think that the way that we do that by being vulnerable sometimes, and like I see someone put in here on the chat, that we are human, that we don't have to always be superheroes, that really can start to shift the environment that we're in. And that is something that we actually can control. So a lot of what we talk about is that you're not alone. In your PA journey, if you felt like you weren't good enough, you felt you've been exhausted, burned out, depressed. Is this a continuum? Are these things interrelated? Are they separate things? Exhaustion and burnout and depression. I've had some students tell me that they don't know, that they don't want to say that they're depressed, or they don't want to say they're burnt out because they don't actually have a formal diagnosis, right? They've never been to a provider who's told them this, and they feel like they're not burnt out enough. So, but going back to what Dathian was talking about with imposter syndrome, I've had students admit that they have imposter syndrome about mental illness itself, right? They're afraid that they're not depressed enough to come forward to say that they need help because they've seen what some of their peers have been through. So I think it really does interplay there. And I really like the way that he highlighted that. One of the best examples of vulnerability and what really prompted a lot of the work that I've done in this modeling behavior that we've done with our students, and then we've tried to propagate here, came from actually our dean. So we were in our first white coat ceremony, and our deputy dean of education at Yale School of Medicine came to do our white coat speech to our first cohort getting their white coats. It's a very big deal. Everybody's sitting there feeling, that I don't belong here. I don't think I should be here, kind of thing. And he stood up and he gave a speech on imposter syndrome. And he talked about how even when he's been at Yale for 30 something years at this point, and they said, do you want to give this speech for the PA program's white coat ceremony? And he was like, he thought to himself, me? They want me out of all the people in the world, they want me to do this. And he talked about how even now, and what he does to get those thoughts out of his mind. And I think it showed our students, it really set the tone for our students that it's okay to have these thoughts, but it's what we do from there with it. And that was such a profound example of his own vulnerability there that he shared with our students. It's something that our students really liked, and they've reflected back on, and they've referenced a lot. So that's one of the things that started us trying to figure out how we can create learning environments that keep that going. So everyone really experiences these different thoughts, whether it's imposter syndrome, whether it's we deal with substance use disorder, if we're just feeling really overexhausted and tired and just not ourselves, or if we do have a formal diagnosis of something like depression or generalized anxiety disorder, or a bipolar disorder, or any of these things. But a lot of times we feel like when we get this white coat, we've referenced it a lot as the white coat of infallibility, right? So when you get this white coat, you feel like all of a sudden you aren't allowed to be human. You're not allowed to have these emotions anymore. And so we know, though, that so many people carry these thoughts, these past, these diagnoses, yet we don't really talk to each other about them. And it's not easy. I started thinking about this with my research, and I was like, well, why don't we ever talk about it? Why don't we ever talk about it? So I create this whole design, the study around it. And I'm like, all right, we're going to have to talk about it. And then I realized that I was going to have to be the one to talk about my own story. And even in that moment, I thought, well, maybe we could cancel it. Maybe I could get someone else to fill in for me, right? So my whole thing was we should start being more vulnerable. But in that moment, when it came down to me going, okay, if I want to do this, then I have to model this, and I have to sit down in this group of people, and I actually have to talk about my weaknesses. I wanted to back out and change the whole thing. So it's really hard to do. It's really hard to put this into practice. And I think a lot of that goes back to how Dathian was saying with admissions. We look for people who are gunners, right? We look for those people who have their straight A's and they've never messed up, and we know they're going to do it. And it's one of those things where we realize that we tell them they have to be perfect all the way through to get into PA school. And then they get here and we're like, no, it's okay. You can be vulnerable. You can take a moment and breathe and relax. But the problem is that that's not the message they've had getting to this point while they're racing to get that next finish line, while they're racing to get into school. So that's something we've tried to work on a lot with our students is, how do you reverse that and you make that okay? And really what we found is a lot of that comes down to modeling behavior from faculty and creating those spaces, those safe spaces for our students to share their own stories with each other and reflect upon their experiences. One thing that I will say, when you do share, it really can lead to these authentic relationships and these deeper connections and communications and understandings of this side of people around us that is typically hidden. One of the researchers that I work with a lot has a personal history of substance use disorder, and he'll speak to that sometimes. And having him, understanding that piece of him, which is such a large piece of who he is and how he's overcome this. And then I will talk to my students and about like that of my history with depression and counseling and being on medication. And it has created this much richer, deeper understanding of each other and where we're coming from and why we're so passionate about the work that we do. On the flip side to that, though, after you share and you engage in these deep discussions, it can be incredibly cathartic for you. Here I was thinking I was going to be benefiting my students by talking about my personal past and showing them that it's okay, that you can be a successful practicing PA educator, but also have a history of mental illness. But on the flip side of that, it really can have kind of an emptiness afterwards. So the only reason I say that is just because if anyone is going to engage in these discussions and really start to share, after sharing, there can be a little bit of a moment where you're kind of like, wow, that was a lot, right? So being time to actually talk to this and actually, take time to recognize that within yourself and knowing it's okay that if you feel a little bit like, wow, that was a little scary afterwards. So I mentioned this a little bit before that we say we're kind of always racing. And we're always trying to get into that next spot. We're trying to get into PA school. We're trying to get that rotation. We're trying to get that elective. Now we see it with the fellowships afterwards and those sort of things. And then one of the things that's come out of this a lot is this role that we were cast in. And this is something that I think about a lot as well now, because I'm the parent of 3 daughters. And I think about the words that I'm saying. And am I saying things, or do I have actions towards them that are perpetuating different parts of their personality? This could be positive or negative, depending on what the trait is and what the circumstance is. But there are certain things that I'm saying or other adults are saying to them that are making them believe certain things about themselves. And I started doing, after I read this book, How to Talk So That Kids Will Listen, and How to Listen So That Kids Will Talk. They talk a lot about this role that we're cast in and how we can cast our children in these different roles as well. And so I did this little experiment they have about trying to change the mindset of my daughter, who thinks that she's really nervous and scared all the time, that she's really brave. And within about a day, she started finding own examples in herself and going, Mom, I was really brave when I did this. Do you remember? Mom, I was really brave when I did this. Do you remember? And so without even prompting, she's changing that inner dialogue. So this is something that I've actually started to try to do with our students as well, and in the workplace also, to see if you can start to do this. So we also talk, though, about the culture of medicine, and that's a role that we're all been cast in, right? When we talk about honesty and admissions, this is one place where this can start. I hear this one all the time. I was in a car accident, or I had this diagnosis, or I helped my sister through this thing, and it was the best care I ever got from a PA. And because of her, I set my sights on PA school, changed my whole major. We hear this, 10 times a day in interview season. But how would you respond if someone said something like this? I have bipolar disorder. I understand the need for a caring provider. I've experienced negative interactions with providers myself, and I want to make sure I provide compassionate care. How do we respond? So taking a moment to think about when someone admits something like this to us, how do we respond when it's physical health versus mental health? And I'll wrap back up to this here at the end when we talk about a more recent study. And then another thing, when we talk about modeling behavior, it can be these kind of 2 voices is how I like to think about it. We get a lot of students who say PA school is really tough. And I've actually heard faculty say, put on your blinders and push through it, right? It's really hard. It's 2.5 years of your life. Get out there and do it. I had a faculty who told me when I was in school that you're going to see really tough things in medicine and you better start learning now. That was one thing that I heard when I was in school, and that still sticks with me and it still bothers me. But I think that it happens, and it's very true that we are going to see tough things, but we can still be human in that process. So how about, instead of saying it's tough and we need to push through, going back to kind of what Dathian was saying, we say, I understand what you're going through. It was hard for me too. And you can leave it there, just acknowledging that it is hard, and it was also hard for you. It's allowed to be hard, right? But you can also take that a step further and say, I felt lonely, isolated. I ended up seeing a counselor, and that really helped me. Just showing some compassion and some humility like that to students can go a really long way. The same thing can happen if you're in an environment. I do this with my colleagues at MUSC as well on inpatient, where it's really hard. And people will say, I feel, wow, I really struggled today. Say, yeah, I really struggled last week. There was a really tough day for me. This is kind of what I did that helped me through it. Just acknowledging that and how people are feeling. So this was a great exercise that actually Indigo helped develop for us in a wellness course that we're running. So right now we have 4 different students or 4 different PA programs participating collectively in a 16-week well-being course. So we have 182, I think it is now, students who are participating from 4 universities. And to bring in this concept of reflective writing with these individual vulnerabilities, I shared my story with students in my past history, and then they were prompted through a discussion forum to talk about, to write about the things you carry. And so some of the students talked about physical things that they carried and what they meant to them. But as you see on here, here are some other things that students responded with this. And so the common themes that came out of these discussion forums, one of them was, I try to, I'm not good enough. And that's that imposter syndrome. And to combat that, they try 110% in everything else they're doing, no matter how small it is. That's exhausting, right? That's really tiring to feel like you can never lay off that gas pedal, that you can never just take a moment and breathe because you're always trying to prove yourself. And students have insight into this, but they're still pushing forward. And I think a lot of providers feel that same way. And then this validation of sacrifice and efforts with others is one that we hear a lot. In another study, we called it the snowflake children. They feel like they're the ones who've made it. You're the one who's in medicine, right? How many people say, this is my daughter, she's a PA, right? This is my son, he's a PA, or he works at this hospital, or those kind of, that's a role that you've been cast in. And you feel like you don't want to burden those around you by saying, but I also need help. And our students feel that way a lot because they are still dependent on their parents in some situations. And they say, I've seen what my parents have sacrificed to get me to this point. If I need to take time off or a leave of absence or to see a counselor, like they're going to see that as a weakness, right? And that can be really scary. In another discussion with students I had, we talk about, saying we want people to come forward and actually talk about and share these things, but also making sure that we recognize the cultural barriers that can be there sometimes as well. I had a student from Croatia, and when we were talking about this through one of these shared stories discussions, she was just crying the entire time. And she said, the things that we are talking about here, she said, I've never talked to anybody about. We don't talk about these things in my family or in my culture. She said, but even beyond that, if I wanted to have these discussions, the words don't exist in her native language. Like these words that we're talking about within vulnerabilities and mental health that we talk about. And she says, I can now have these conversations with my classmates. She said, I couldn't translate these to my parents. These don't exist because mental health is not something that we talk about. So recognizing that within our patients and our peers, and those around us, that our cultural influences can really drive how we're able to connect with each other. Another one, and I'll say that I'm not an expert in this at all, but it does overlap, I think, a lot with the work that Dathian is doing, and what he talked about here is that this duty to represent the entire group. So this, again, was ones that our students put on here. Where this student, she felt like because she was the one who made it from her community, is what she said, is that she feels that everything she does not only represents her, but her entire community. And that's a lot of pressure for someone to carry with them. That's a lot of pressure, to be thinking about when you're also trying to just make your own career and be successful and make the decisions for yourself. I see this a lot with our students also who come from rural and underserved communities as well, that they feel like that they have to go back. They have to go back to this community because they were raised in this community, that they have to go back to this community. Even if they don't necessarily want to, they feel like it was their duty to serve this community and to go back there. So engaging in these conversations with the people around us can really help us understand them and help each individual just work through it. Sometimes we don't need a solution, and we all know this because we've been in this situation. You don't even need a solution. You just want to be heard, right? So creating that space for your colleagues where you can engage in these real discussions and let someone be heard and just kind of voice what they're thinking, and then just acknowledge what they're thinking. You don't have to have the answer, and that it really can just be about just acknowledging it. So one student feeling like she feels like she has to overcompensate to reverse the image that people have of her and her community. So these are all things that our students are thinking about while they're also trying to go through school. So when we talk about self-disclosure, there's a lot of different components to it. And these are just some things to think about. And what are we actually disclosing? Is this just, I'm really tired, I'm really exhausted today, or I just haven't felt like myself lately? Or is this disclosing something in a more formal setting? Where, like I've done with students, where I actually talk about very detailed diagnoses and histories there, thinking about who are we disclosing it to? Are we talking to ourselves, or just admitting it to ourselves? Are we talking this to our family, a friend, someone at work, colleagues, our students? Or is this something where we're disclosing something to a medical board? As us as licensed providers, with our duty to protect the general population, we do have to be aware of these things. So what is it that we're actually disclosing? And one of the things that a lot of states talk about is clinician impairment, and that's really poorly defined. Is impairment just being tired? Is it not being able to perform your job function? In some situations like substance use disorder, it's a little bit more clear what it means with that. But if you're depressed and you're getting help and you're seeing a counselor and you're on medication, it's not really being impaired at that moment. But there's not a lot of definition around what clinician impairment actually means, yet a lot of these different state laws are the licensure applications and things like that have a lot to do with clinician impairment, and they use that verbiage. So one thing that it would be important to look at if you are going to come forward and talk about these different things and talk about your past is, what does your regulatory board actually say about this? Do they define clinician impairment? And is it clearly defined what happens? So a lot of us will see those boxes when we go for relicensure. And it says, depending on the state you live in, it says different things. But some of them ask about if you ever seen a counselor, but some of them ask about very specifically, like, have you been able to perform your job in the past 12 months, or those kind of things. And there are different ways that we can go about it, but we really have to understand what our regulatory board says. And then from there, we don't necessarily know what those next steps are going to be. And that can be scary in itself. So if you check that box that says, yes, I'm seeing a counselor, I have a diagnosed mental illness or something, what happens next? And the unknown around that, I think, prevents a lot of providers from coming forward, but it also prevents us maybe from being truthful on that box, right? Maybe we don't want to check that box because we don't know what happens when that happens, and it's not that the risk isn't worth it. Or maybe it goes a step further and we just don't get help altogether because we're afraid of what might happen if someone were to find out. So there's a lot of implications with that because we have this, licensing board as well. So another experiment that we did was about modeling this behavior and talking about different things when you actually do share your story. And these are just some of the reflections from some students as far as what they felt like after they heard a story. It can be as simple as replying with like the two voices example and just saying, I felt that way too before, or going further into it and getting more detailed and kind of validating, hey, it's okay if you think you need help. Right? You can validate that and take that a step further, or just acknowledging what they're saying. Letting people know that they're not alone. This is one that we hear a lot from students is, I thought I was the only person who felt this way, or everyone else looks like they have it together. So I didn't want to be the one with a problem, or I didn't want to be the one to admit something because everybody else seems like they really just have it together. So I think there's a lot to gain from sharing our stories with each other, and from actually being truthful with ourselves and just being honest with the way that we speak about our own mental health with our colleagues. So this is the ADA compliance stuff, and this was from an article that came out in JAPA that we worked on, but looking at initial state licensure compliance with the ADA. And the way that we looked at ADA compliance was it had to contain questions about current physical or mental health conditions that impaired your ability to practice as a PA. So that's what we said, as we determined as a research team was consistent with the ADA. They could not ask questions that said they may cause impairment, no speculatory questions. So we found that only 49% of states were compliant in physical and mental health questions with the ADA. So I have very, very, very preliminary data as of like, a week and a half ago from the second phase of this study, which was when we are looking at compliance of renewal licensure questions. But with that, we're also matching that with a few survey questions. And so with the help of AAPA, we had over 1,500 responses for this. And what we have found very, very, in our, like I said, incredibly preliminary data here, though, is that 35% of these 1,500 PAs thought that they would be concerned about licensure repercussions with mental health or a substance use ailment. So that's 35% of PAs saying, I'm concerned if I had to get help or if I had something wrong, that it might reflect poorly on my license. And then we think about what happens with those providers. Do you get help or do you not? Because you're afraid of what might happen if people find out. So it really does have some real, the licensure for us really does have some real potential repercussions for the mental health of our practicing providers as well. And then I saw someone put in here in the chat talking about students who are afraid to get help as well, because they're afraid they're going to have to disclose this. So they're afraid they're going to have to check that box. And unfortunately, 51% of states still have questions that are not necessarily ADA compliant. And even though you cannot legally discriminate against someone for that, why are we then asking those questions, right? So if we're asking those questions, what are you doing with that information then? And sometimes just that unknown, like I said, that unknown around what happens when you check that box prevents people from wanting to do it. So it is something that we're seeing a lot with students. And I feel a little bit hypocritical with this when I tell my students, come forward, get help, come forward, get help. And I have students right now in, I think, 36 different states. And some of their states are going to ask them these questions, and that can be really challenging for them as well. Yeah, so Carrie was saying on here as well that they have forms from new grads that are asking for references and asking if they're aware they have any mental illnesses. And what that question should be is anything that's impaired their ability to practice, right? If they're even asking about it, it's current impairment or their ability to perform their job, not if you've ever had a history of mental illness. The example I give on that is some of the forms will say things like, have you ever seen a counselor? Well, I take my daughter to counseling. She's 5. We go to family counseling together once a month. Do I have to disclose that I go to family counseling with my daughter on one of those forms? In some states, though, yes, that's what they're asking. And I think, how does that ever even affect at all remotely my ability to practice as a PA? So there are a lot of things to consider there. So as I wrap up, I always like to leave my students with a challenge. So I want to go ahead and put one on here for you. And that writing prompt that you saw that Indigo had put into our course for us, but write about the things that you carry. This is incredibly reflective. And so I challenge you to take some time after this and actually write this down. And then if you want to take that one step further and actually get into that shared stories, like I've talked about, try and actually share this with somebody. Sit down and say, I wrote this. Can I share with you what I was thinking? And then try to engage in real discussion around that. And then the next time that you're faced with this kind of I did it, now you do it mentality, see if you can pause and change that inner dialogue. Yes, you may have been told that, and that's the role that you were cast in as a PA and as a medical provider. You know, we push through and it's a hard job and we have to be really tough when we do it. But see if we can change that dialogue and maybe show a little bit of humility in this and say, you know, I've really struggled with that too, and see if we can shift that. So if anyone has any questions, I think we are going to engage at the end in some questions with that, but thank you all very much. I think we have one more person.
Thank you very much. I appreciate that. Very important research that you were sharing with us there that I'd love to talk more about in the follow-up. But we will move on with our last speaker in this panel group before we move on to some question and answer. We have Heidi Brown, PAC here. Heidi has been working in medicine for the last 21 years as a psychiatric physician assistant since 2009 in Idaho, Oregon, and Utah. She's a member of the American Association of Physician Assistants, Idaho and Oregon Physician Assistant Organizations, the American Psychiatric Association, and the Neuroscience Education Institute. She enjoys giving back and has worked on multiple medical humanitarian missions. Heidi believes strongly in education and has worked with the University of Idaho's Physician Assistant Program on multiple psychiatric topics. She also provided consultation and practical workshops to develop the first PA student wellness program for the University of Idaho in 2019. Having experienced her own burnout, she co-founded the Burn Clinic, an organization designed to educate students on risks of burnout, promote wellness in PAs, and to destigmatize burnout. So without further ado, I will turn it over to Ms. Heidi Brown. Thank you.
Hey, thank you so much. I am sitting here, even as you say like nice things about me, I'm like, yep, imposter syndrome. I still don't feel like I've done enough to belong here. I am definitely a burnout survivor and have experienced, imposter syndrome. I experienced imposter syndrome, especially like my first 3 years practicing as a PA, practicing psychiatry. I was really, really sure that any day somebody was going to find me out and that was going to be the end of it. Fortunately, I have developed more tools to be able to kind of cope with that part of things quite a bit better, but continue to find, imposter syndrome popping up throughout other parts of my life and my challenges as I try and grow and do other things. And, I've spoken at all kinds of different conferences with AAPA, state conferences, international conferences on burnout, but still, I took Dathion's recommendation and I did the online imposter syndrome like quiz, and I scored pretty darn high on it. So I just want to let you share that vulnerability that Stephanie was also kind of talking about. And I often, start off whenever like I'm participating in doing some of the workshops and making these self-care plans. And I do usually start off my presentations with kind of my story as well, because I do feel that that is so important into relating to people and my experience of, coming from a really kind of underserved background, being orphaned when I was young, and then going through college and kind of making things work somehow amazingly. And I think it is important for people to hear that and hear that vulnerability. So I'm really, really pleased to be on this panel with Dathian and Stephanie. And even though a lot of what I'm going to be talking about is still some of the back to the basics things, because we have to kind of work on this hierarchy of needs. And, a lot of my ideas are, you're never going to get to be where you want if you don't know what you want. And we often just kind of get stuck in this hamster wheel of doing the same things over and over, day in and day out, feeling like I don't have control over things. Things are never going to change. I don't know how to take these like practical steps to make anything actually happen. So the first part of my discussion today is some of the harms with PA burnout. And this is definitely something that is explored to different degrees with a lot of these panels. And then we'll kind of go into looking at what does a self-care plan look at? Why is it important to have one? And also assessing like, what do you want out of an ideal job, so that you can look at what you have with your current job, where's your overlap, and where can you be making changes? So I will share my screen here in just a second to get to the PowerPoint. Here we go. I'll get it out of presenter mode. Give me just a second. And disclosure is, I am the co-founder of the Burn Clinic. It is a nonprofit organization for education, treatment, and prevention of burnout for medical providers and students. I actually started my student work much longer before 2019, but we have been now working with several universities implementing different programs for student wellness. And really there again, looking at like this kind of long-term prospect of, having careers that are sustainable. So what are some of the negative impacts with burnout, and what happens to us and our patient care? A lot of our patient satisfaction can be impacted if our providers are burnt out. When we do surveys assessing having the patients do analysis of their providers, they can see that their providers are burnt out, but they can have longer time for healing and lower patient satisfaction. So this is the increased recovery times. So providers scoring higher on the MBI correlated to longer patient recovery times, but also, like I was saying, when patients perceived that their providers are depersonalized, they had longer recovery times. So I like, kind of the analogy, it's kind of like being an alcoholic. You're not really hiding it from anybody. There's negative impact on positivity, and with positivity that can affect our cognitive vigilance. So we tend to give lower quality of care and less involvement with our patient care. There's good data all the way back in the 80s showing that when we do things to implement burnout treatment, basically, and provider wellness inside of organizations, large organizations, that there can be up to a 70% reduction in malpractice claims. And so we know that this helps our providers to just be more engaged and more cognitively vigilant. Oftentimes when we become burnt out, not only are we less present and less there, we become less productive. So we'll cut back our full-time employment. And there's a direct correlation with rates with MBI scores and decreased reduction in full-time employment. But beware, if that's something you're considering with your burnout, that there definitely, of course, is the potential that you're not really decreasing that much. You just might not be getting the same amount of benefits because people tend to still take a lot of it home and struggle with that balance. Negative impacts on our families, increased strain in relationships. We're not really meeting other people's needs to the way that they need them met. Our time together is not quality time. If you want to turn sexy off, bring home work. Nothing says sexy like a blue light of a computer in bed trying to finish up charting. And of course, we know there's negative impacts on children when parents exhibit depression and anxiety that are inherently part of burnout. Children are more likely to exhibit social isolation and anxiety as well. Depression and suicide. Dathian touched on this just a few minutes ago as well, and I thought it was really, really great. And emphasizing the fact that healthcare providers have higher rates than the general population, but especially females do, because in the general population, usually men have a significantly higher rate of suicide than females do. However, in healthcare providers and physicians specifically, the rates are about the same for males as they are for females, which actually put women physicians at 240 to 400% higher rates of suicide. So very, very high rates. And of course, as PAs, too, this is important to us. And 68% of PAs identify as female per NCCPA. So the prevention and treatment, creating awareness that we are all at risk. I also love, Dathan brought up, like we draw these type A personalities and he's just 110% right. And we tend to be at higher risk just because of the people that are drawn towards it. But also as PAs, oftentimes we're seen as like the workhorses. So we don't get necessarily the same glory or pay as our MD counterparts, but we're seeing the patient loads and we're taking care of the people, and we aren't necessarily always getting the same amount of kind of credit for that, so to speak. And that even of itself creates unique risk set factors for PAs. So what do we do about it? Back to the basics, right? So we have to start by creating balance in our work environment and balance in our personal environment. Lily earlier did a really great job too. I really, really appreciate, her kind of talking about necessarily it's not just like one box and another box, that there's a lot of kind of overlap between the two when you talk about like balance. It's not work is here and life is here. So developing a self-care plan. A self-care plan is really like this is how you get started point. So this is like, how do you get from one side of the Grand Canyon to the other? One step at a time, right? One step at a time. So this is kind of a first step in developing kind of where do you want to be? Where are your weaknesses and where are your strengths? So self-care plans can have all kinds of different components to it. This is based off of one that I use in other programs and workshops, kind of a 7-point kind of self-care plan. And with this self-care plan, we look at like, where are you at professionally? Where are you at with your workplace? Where are you at with your relationships? Where are you at psychologically, emotionally, physical? And then the last one is really what I feel to be the most key part of having a self-care plan. And this is the accountability. You need to make sure that this is not just, fluff, and we're not just showing up and listening to these things and then not doing anything about them. The accountability makes it something that is realistic for you to be able to make these changes instead of, oh, that seemed like a nice idea at the time. I remember kind of talking about that one time. This is how you actually make things happen. So when we talk about the self-care plan, we look at the professional aspect. So in your professional aspect, like, what are you using your money for on your CMEs? Well, I can tell you everybody here today is doing a great job of using their money for their CMEs for kind of their professional development, because we're looking at how are we going to be able to sustain our career? And because, the problem with burnout is not that it's a problem, because if it was a problem, it would have a solution. But it's not just a solution. These are ongoing things that we have to work at. So kudos to everybody here for spending some of their CME money on working on things that will keep you to be able to maintain a healthy and great career. Also, what are you doing to connect with others and peers? This, of course, is a significant challenge with COVID, but are there other things that you could be doing too, such as like teaching, going to conferences, signing up to participate in conferences or do lectures at conferences, precepting and students. It doesn't have to be just PA students. It also can be, sometimes, we work with our medical students or nursing students, or people who are just kind of excited about medicine and want to see if this is something that they are going to be doing. Workplace, so setting the boundaries, separating work from home, prioritizing things like, do you need to be on that committee at work, or is that really just taking away from your lunch, twice a week, and instead you could be going for a walk in order to help reset yourself. So being able to say yes to you. We talk a lot about being able to say no, and I'm trying to constantly kind of challenge this mindset, because I often hear from people like, I'm just not good at saying no. I'm just not good at saying no. But you are, as a PA, you are very good at saying no. We tell people no all the time. No, antibiotics are not appropriate for your viral infection. No, you don't need pain medication for your stubbed toe. No, because you feel a little bit anxious, I'm not giving you benzos to use every day. Like, we are good at saying no. What we aren't good at is saying yes to yourself and prioritizing yourself. So just challenging that mindset of when you say, no, I'm not going to take an extra shift. No, I'm not really interested in being, in that committee or doing whatever it is that someone else wants you to be doing. That you're not really saying no, you're saying yes to you. Other things like, should you be working on with your workplace in your self-care plan? How are you doing with your efficiency? How can you get home sooner? Do you need to set up time with your administration in order to do some more efficiency training, just even working on the shortcuts of your program to be, just kind of shaving off that extra time that you're spending at work so that you can be spending more time in other places. In our self-care plan, we want to be looking at our relationships, that we're prioritizing our close relationships in ways that are important to them. I talk a lot still about like love languages. How is it that other people show their love and feel that they're being loved? Is it by touch? Is it by gifts? Is it by time? What is important to them? And just taking a minute to kind of analyze that. Is that something that you've done in your relationship recently? What have you done to help someone else feel special? And when you're with other people, do you give them your undivided attention? This is something that I think is very hard for us just in general with medicine, because we're kind of constantly thinking, like, did I recheck those lab results? I wonder if the MA sent the messages out. I wonder if this was ordered. I wonder how that person is doing. And so we get distracted by all these other things that are going on inside of our own head. but are we giving our loved ones the relationship attention that they need, our undivided attention? So psychological, a lot of things that we've been talking about here today again as well. And so the first kind of step of that, I put, turn off your work emails, notifications outside of work hours. And so that's like kind of that first step in setting some boundaries so that you can have some of your mindfulness and being kind of present in the moment without being constantly distracted by these things. And even if you can't, turn off, like if you're generally an on-call person, maybe you can set small boundaries, like with your medical assistant when they're calling you, like between the hours of 5 and 7 p.m. I will not be immediately available. I will call you back though after 7 p.m. with any messages. So that you're setting even just small boundaries. What are you doing for non-work hobbies? What are you doing outside of your PA bubble, outside of your PA world, in order to be enjoying yourself and working on yourself psychologically? Engaging with positive friends and family. Note the positive part, right? Like we all have family who's a little bit like difficult to kind of to deal with, and sometimes or friends, and it's still important to spend time with those people and give them attention and everything. But what are you doing for the positivity for yourself, building yourself up? Engaging with mentors or supportive work colleagues. And then also spiritual. Is this something that you've done in the past, but you've kind of neglected? Do you need to be working on picking these pieces back up, or going deeper into it, like whatever it is that kind of helps heal you kind of psychologically? Emotionally, how are you in touch with yourself emotionally? So highs and lows, it's basically kind of a game that we play with our family, that was we started like many years ago. We do it at dinner time. It was recommended to me by one of the LCSWs, one of the clinicians that I work with one of the mental health clinics, where you just on a daily basis kind of touch in, what was my highs for today? Where were my lows at today? What was the best part of the day and what was the worst part of the day? Just really touching in with yourself. We do this as a family so that, I understand, well, also then like maybe some more of the mindset of like where my kiddo is at. My kiddo, I mean my 15-year-old who's 240 pounds and power lifter. He's pretty much grown, but it really helps me get some insight, where his stress levels are. And also the same with my husband. So highs and lows, this is more kind of a day-to-day check-in. Emotional, being aware of the positives. So again, kind of like where are you at with your kind of mindset? Are you checking in with like the positives of what's going on and appreciating whenever little things do happen that are positive, and realizing that sometimes the little things are the things that are really important. So for example, like if a patient says thank you, so take just a second maybe to think about, when was the last time a patient said thank you? And how did you respond? Did you say, oh yes, you're welcome, and out the door they go, and on to the next patient because you're running behind? Or were you able to really kind of appreciate that whenever somebody else said thank you, and be able to take a moment and tell them you're welcome, or I really enjoyed doing this, for you, or this is why I practice medicine, is to be able to help people. Were you able to appreciate the positives? And then, still on an emotional level, a little bit of that kind of accountability. Do you talk with your friends, partners, or clinicians about your emotional well-being? Also here, potentially about their emotional well-being. This is a self-care plan for yourself, but if this is something where you're really strong at, then maybe it's time to kind of take that next step and be talking to other people about how they are doing with their emotional well-being. How are you doing taking care of yourself in a physical aspect? How's your sleep hygiene? Like maybe you should be using blue light glasses before you go to bed, or melatonin, or setting better schedules, or turning the electronics off. Like how is your sleep? If you don't sleep well, you don't function well. Kind of bottom line, constant thing that I preach in my practice. If you don't sleep well, you don't function well. How is your diet? We know there's all kinds of direct correlations between crappy diets and higher levels of depression and anxiety. So we don't want to be not taking care of ourselves physically and feeding into these other symptoms of burnout just by what we're putting in our mouths. Chocolate, of course, is always the exception. There's some good positives to it, but everything in moderation, right? So just kind of a check-in. How are you taking care of yourself physically? How is your diet? And how is your physical activity? Are you doing things to stay busy that you want to be doing to take care of yourselves? Are there small ways that you could be prioritizing this a little bit better? Are you using your sick leave when you're sick? Or are you just a soldier who powers through and nothing's going to stop you, even if you're sharing it with everybody else? Like, again, just kind of taking care of yourself. And then the accountability aspect. So I really encourage, people to write all of these things out, but not only write them out, verbalize it and commit to it. And verbalize it and commit to it to somebody else, and somebody else who's not an enabler, right? Because we all have those in our lives too, who are like, oh yeah, look at you, you're doing so good. But we want somebody who can maybe, tell us and say, hey, like, are you really going on your walks on your lunch like you said you were going to, or you're just talking? And being able to have that kind of follow through, and be able to say, you talk to them after kind of writing this all down and discussing, like, how are you going to actually make these happen? So the next little part here is discussing kind of our ideal job, ideal life, and where are you now? So we'll really run through this in the aspect of, like, what is your ideal job? Because an ideal life, because where are you now is easy kind of to assess. When we look at our ideal job, we want to assess kind of several different aspects: practice type, compensation, management, schedule. Oops. And so with the practice type, what we're looking at is, what kind of practice are you wanting to be in? How big of a practice? What type of location? What type of commute? Are you want to be doing telehealth, or do you want to be doing in person? What is it that looks like for you? Compensation, how are you being paid? Hourly, salary, percent reimbursement? What is it that ideally would work out best for you? And kind of the amount of compensation that you're ideally looking for your ideal job. Management, how important is it to you that you work really independently? How important is it to you that you're in a large group and that you have a lot of management support? What does that look like for you, and what do you want out of your management? Your schedule. Autonomy and schedule, we know, is something that is extremely important when it comes to burnout. People who have to schedule 6 to 8 weeks out in order to get an afternoon off to take their kid to the doctor tend to have really a lot higher levels of burnout versus somebody who's able to say, hey, I'm going to have to take 3 hours out of clinic in 3 or 4 weeks, and it's not going to be a big deal. But also, what does your ideal schedule look like? Would you like to be able to work 3 10s or 4 10s or 2 days a week, or 3 half days a week? Like, what does your ideal schedule look like? Perks. What else are you getting out of this job? What's your PTO? What's your CMEs? What's your benefits? Are they getting your 401k matched? Are you getting PTO? What do your perks look like? Is there paid maternity leave? What do you want ideally out of an ideal job for perks? And then the ideal life: relationship, family, home, adventures, and retirement. So ideally, how would your relationships look? So, and this is your primary kind of relationship, if you're in a primary relationship, or you're kind of really your closest relationships. Are you would you want to be spending more time with them, showing them that you care more about them in a way that's meaningful for them? What's important there? Family. Do you want more people in your family? Do you have kids that are going off to college? What does things look like in an ideal situation? Your home life. Where are you living at? Are you living next to other family members, friends and family, or do you want to be pretty remote and away from them? What size of home, what type of home life is ideal for you? Adventures, do you have anything planned to be coming up? Again, a lot of things have been put on hold by COVID, but you know, it doesn't necessarily have to be travel for our adventures either. It could be learning to salsa dance or crochet or sew or anything that is kind of outside of kind of your work wheelhouse. And retirement, what does your ideal retirement look like? And what age would you like to retire? How much money would you like to be getting a year after you retire? Maybe you're not really into retiring or ever foresee yourself fully retiring and you want to work, you know, 1 or 2 days a week doing clinical work or research work or university work, but just kind of getting you thinking about what does that ideal look like. After kind of going through those, then you can take a moment and go back through and see where are you at now. Start to look at like where the overlap is in each area. Generally, a pretty successful ideal job, ideal life overlap is about 70%. We're never going to get to 100%, right? This is not a utopia. Back here in reality, it's just not going to happen. 70% is doing pretty darn good. So where are you not overlapping? That's what I want you to be looking at in order to understand better what you can be changing. And now is the time for change, of course, right? So just kind of even thinking about these, if you aren't kind of writing them down, what can you commit to working on? And just choosing 1 or 2 and writing them down so that you can make a solid plan on implementing where, when, and how you can make these changes in the next week or 2. Just even small things.
We have a few, well, we got a lot of questions, a lot of interest. I think we'll just have to make a little selection of a few to get started here. So a few came through for Dathian when he was talking about imposter syndrome. I saw that you had answered one in the chat already. Indigo had mentioned, I really like the inner saboteur as an alternate framing. I wonder how we can move from imposter phenomenon to intellectual humility in recognition that we're on a trajectory and to make peace with how much there is to learn. I saw that you answered that. I wanted to kind of break that down to a more basic level. A question I had was, how do we know when we are suffering from imposter syndrome or imposter phenomenon, or just have a weakness that actually needs to be addressed? How can we balance that as clinicians or students or educators?
So usually, you know, you kind of know. You feel like this inadequate sense of belonging. You feel like you're always constantly trying to prove yourself, or like what a few people mentioned earlier, that tokenism of, oh, the whole weight of my race or my gender, my sexuality lays on my shoulders, and I'm here because they just need some type of representation. So I call that stinking thinking. If you're having these stinking thinking moments, try to take away that perception and try to focus on the reality. Like, okay, I'm here, why? And focus on your why. But also, like we said, that culture of authenticity, that shared story, that allows people too to tap in to say, you know what, maybe what I'm thinking might not be the whole truth. It's my truth at the moment, but how can I move beyond that? So I think really normalizing it, having discussions, and then, you know, beyond just trying to help yourself, go to a professional too. Someone who can help you, a therapist, a counselor, someone who can give you some tools to put in your tool belt to pull out whenever you need that. So, you know, that's my roundabout way of kind of saying that's how you can recognize you have a problem. But it's not just a recognition, it's next, what am I going to do about it?
Yeah, that external validation sometimes helps solve some of that. That external assessment is important. Stephanie, you talked a lot about, obviously, about vulnerability and disclosure and why that's difficult. I was wondering if you could just elaborate briefly on how we can, as a culture in healthcare, make it okay to be vulnerable without getting these labels of being broken or somehow not good enough. You know, what can we do as a community to sort of make that more okay?
Yeah, and I think if I had that answer, I think we'd all be better off. I think that's what we're all trying to kind of work towards here. But I think that one of the things that at least I've tried is being true to myself, and like Dathan just mentioned, like what are your truths, and recognizing that if I want to have other people be vulnerable and I want this to be okay, there's a little bit of that point where it's going to have to come from me. Like I'm going to have to create this environment for my students, for my peers, if it's not already there. And making sure that, I might have to take that little bit of a risk. And that's scary, like I said, to put yourself out there like that. But to create those little pockets for conversation. And maybe it's not in a very public setting, but now I do it, in advising meetings. If I have students and I can just talk to them one-on-one on something, or if I have a colleague who's maybe gives a little bit of a step or hints at, something that's struggling, rather than just saying like, oh, did you have a good day? And people are like, oh yeah. So, how did you feel today? Like, what else is going on today? And trying to like unpack that a little bit more, and allowing people to get beyond that initial like, oh, I'm good. Hey, oh, hey, how are you? Allowing people to kind of unpack that and really have that space to talk and to share.
And one of the elements that you mentioned specifically was this idea of regulatory boards sort of furthering the idea that there's stigma, or there's barriers to being vulnerable, or being true to, or even seeking help. Like Dathan mentioned, seeking a professional that might, get you tagged with a diagnosis, so to speak. What can we do? Let's say we're not suing our medical boards, right? Like what can we do as a group of people to sort of change the messaging around that? Because we're not trying to all go to court to sue people based on the ADA, right? So what can we do to sort of break this in a more social way, and not in taking a legal avenue?
I think one thing is being aware. Honestly, until I started doing this, I had no idea. I didn't happen to live in a state that was non-compliant. So I honestly had no idea that other states were even asking these questions. So I think part of it is becoming aware of what your state is actually asking, and, where you're located, and what are those questions that you have to answer. And then from there, once you've armed yourself with the knowledge of what's there, is trying to just open up that dialogue around it, to kind of create some advocacy efforts to change that messaging. Because like you said, we're not trying to say everyone go and sue your regulatory board. We're saying, hey, maybe we should take a look at these questions that maybe haven't been updated in however many years, and look at these as a whole, and maybe make some updates to these.
Yeah. Heidi, you talked about some self-care plans in your talk. I guess if so much of the messaging around burnout is it's not a problem with us as individuals, it's a problem with our environment, why should we bother creating self-care plans or individualizing this if it's not our fault?
Right. And because, and well, I think like our next panel is going to kind of talk about more what we can do with like the institution and the organization level too, which I totally am like excited about and appreciate. But this is like our starting point. So like I kind of talked about, like, it's really kind of on this hierarchy. You have to check in with yourself and know where you're at, and you have to be in a good place in a lot of these areas in order to be able to address the bigger picture, the bigger problems.
Thank you.